Hello, and on behalf of the Scientific Committee, can I welcome everyone to our 23rd Annual Cardiology, Diabetes and Nephrology at the Limits meeting. As you are aware, this is a virtual meeting in which we have 1,500 delegates from over 40 countries around the world who have registered for the meeting. My co-chairpersons, Professor John Cunningham and Professor Stephanie Baldovec, and I are presenting this meeting from the Royal College of Physicians in London, with all our other co-chairpersons also supporting us from their institutions in both Boston, and that is Professor Mark Pfeffer and Professor Peter Libby, and from Cape Town, which are Professor Brian Rayner and Professor Mapika Niseki. In addition, all our speakers will be giving their presentations online from their various countries. We have a superb group of speakers addressing a range of exciting and different topics, which we hope you will enjoy. On a sad note, however, our first presentation, which was supposed to be the Lancet lecture given by Professor John Deanfield, has to be postponed because unfortunately he was taken seriously ill just over a week ago and is in hospital undergoing treatment. But he assures us that he will be ready to give his talk at our next meeting in 2022. This meeting will be over 2 days and will last approximately 2.5 hours each day. We also asked all our speakers to create 2 presentations for you to enjoy. If you look at our event website, you can see their full in-depth slides, diving into the full detail of their topic. But on the webcast today, we'll be featuring just a shorter 8 to 10 minute summary videos, followed by live Q&A, where we can quiz all the speakers on their findings and presentation. We hope that you will send your questions to the chairpersons of each session. So with this, let me hand you over to my co-chairman, Professor John Cunningham.
Thank you very much for the introduction, Derek. And let me add my welcome, please, from London, on behalf of the organising committee here to this virtual meeting, which I hope will be succeeded in a year's time by a real meeting of similar content, also in London, and I look forward to meeting as many of you as possible at that time. I'm going to move straight on to introduce the first speaker. We have an excellent faculty here, and we're starting with a very high bar indeed in the form of Professor Sir Stephen O'Reilly, who will open the meeting. Professor O'Reilly is the director of the Wellcome MRC Institute for Metabolic Science at the University of Cambridge. He's a world authority in the science of obesity, and that chimes nicely with the title of his talk, which is What Makes Us Fat? The Science of Obesity.
This is where I work, the Institute of Metabolic Science in Cambridge, and in it my lab addresses 2 questions. Firstly, why are some people fat and some people not? And secondly, when you do become obese, why do you become ill? In the talk today, I'll very briefly touch upon the first question and spend most of my short time on the second, and possibly end with a little mention of the intersection between obesity and the COVID epidemic. So broadly, obesity is due to gene-environment interaction, and what we've discovered over the last 20 years is that those genes are largely expressed in the central nervous system. When there's famine, nobody is obese, and when food is restricted, very few are. But in conditions of food superabundance that we currently have, then a large range of individuals become obese to a variable extent, largely dependent on their genetic inheritance. And what we've learned about those genes from studies of large populations, but also of rare individuals, is firstly that they're mostly brain-expressed genes, and many of those, when we study them, affect appetite. And what we've learned in detail is that the leptin-melanocortin system, deep in the hypothalamus of the brain, is a critical regulatory system in this whole process. I'll just share with you briefly some in-press data from a study we've been doing on one of the key elements of that system, the melanocortin-4 receptor. We studied it with colleagues in Bristol in a birth cohort, the best way of studying a disorder's prevalence, because you're not selecting for anything. You're just selecting a group of people born in a particular year, in this case 1991. And there we found that about 1 in every 330 people had a loss of function mutation in the melanocortin-4 receptor. That's up to 200,000 if we estimate for the UK, and maybe as many as 20 million people in the world. The thing that we found astonishing is that the impact and the size of the impact of carrying that. Every carrier, on average, carried an 18 kilogram weight gain into adult life at the age of 18, 14 kilos of which was fat. So this really means we need to focus down on this population who are entering life with this huge weight disadvantage. And now that we know the genetic cause here, we can design appropriate therapies to try and bypass this defect. So to move on to the adverse consequences of overnutrition, firstly, I'd like to say that really obesity is simply a result of the chronic imbalance between energy intake and energy expenditure. And the expanded mass and volume of triglyceride in adipocytes is what's directly responsible for those mechanical and gravitational effects of obesity. But it's hard to see how that mass could directly impinge on things like the risk of cancer and metabolic disease. And perhaps obesity there, the mass, is just a biomarker for this chronic excess of energy intake over energy expenditure. So central to these metabolic disorders is the problem of insulin resistance / hyperinsulinemia. And an understanding of how overnutrition leads to insulin resistance is really a holy grail for the understanding of why obesity is bad for us. So how do we get from sustained positive energy balance to defective glucose handling in liver and muscle, which are the key tissues for insulin action? If you asked 1,000 diabetologists at the moment, they'd probably answer you, it's because of these inflammatory cells in fat and all these adipocytokines. And animal model research would strongly support that. But I would like to say that there's very little human genetic evidence or indeed human pharmacological evidence to support this notion as being critical as the link in humans, or at least the key link is in humans. And better evidence is emerging for another model. And that model is that our fat cell is the safest place to put our excess energy. And when we start reaching the limits of safe storage in that fat cell, we start redirecting nutrients to those non-professional nutrient storage tissues. And that's where the mischief really starts. And a very good model of this are people who are born with an inadequate adipose store. These people are born with inability to make triglyceride or inability to make fat cells. They have so-called lipodystrophy. So they're not obese, but they develop all the metabolic complications of obesity because they redirect all those nutrients away into those non-professional stores. Together with my colleague David Savage and other collaborators over the years, we've discovered many of the genes causing lipodystrophy, but I'm going to take you to one rare example just because it's a beautiful example of what sorts of mechanisms might be going on and how it might be more broadly significant. People with a mutation in perilipin-1, which knocks off this mutation, which messes up the very end, the so-called C-terminus, develop a very specific and severe form of metabolic syndrome and lipodystrophy. And they do so for the following reasons. Perilipin lives on the surface of the lipid droplets, only in white fat cells. There it lives with its partner, CGI58. And when you're being fed, it just sits there doing nothing, and your triglyceride droplet makes fat. But overnight, in the middle of the night, when you need your free fatty acids to keep your heart fueled, you get a phosphorylation event, hormonally induced at the C-terminus, that kicks off CGI58, that kicks the lipase that breaks down triglyceride, and you have this beautiful coordination of fatty acid delivery to your body to allow your heart to keep working overnight. Without that, you'll be in real trouble. But these unfortunate people just have one messed up copy of perilipin. All day, every day, they have this molecule floating around, grabbing down the lipase and making them make fatty acids that they deliver to the body. And that alone is enough to lead to every abnormality we see in obesity. So this constant release of free fatty acid from the adipocyte is sufficient in itself to lead to the metabolic syndrome. Is this relevant to more common disease? Well, we tried to ask that in collaboration with our colleagues at the MRC Epidemiology Unit by getting a composite score of metabolic syndrome associated with fasting insulin, low HDL and high triglyceride, and finding 53 common variants that impacted on that. And here they are here as defined in red for high, blue for low, red for high, looking at different populations, independent studies. Yes, these SNPs are associated with worse coronary artery disease and worse diabetes, but looking at them against body fat measures, it's really surprising. They seem to be associated with leanness, not with obesity. And so when we take these into a DEXA scanned population, over nearly 13,000, and ask, if you carry these risky SNPs, do they give you a big belly? Well, not really. The bellies aren't that much bigger. What do they give you? They give you a small bottom. They give you a low fat in the legs, low fat in the gynoid region. So really we're talking about these risk SNPs in the general population, preventing safe accumulation of fat on the safe areas, the legs and buttocks, rather than driving them into the visceral fat that we so often talk about. And therefore I often use this model to try and explain this to a lay audience. If you've got a bathroom where somebody's left the tap on and left it plug out and there's a mat on the bottom, everything is healthy because you store the triglyceride there. And we think usually about obesity diseases as a following way. People eat too much, take in too much food, or expend too little energy, and then the bath overflows and you get the soggy carpet. But of course we think far too little, I believe, about the fact that not everyone has the same size bath. In other words, people are born with varying degrees of adipose storage capacity. And so for some people, they can remain healthy while being very obese. Others become sick who have limited adipose storage capacity and develop all those problems. And we're moving from this as a generality into very much more specific areas of research at the moment, looking at rare variants. This one is called ALK7. It's present in 1 and 2 in every 1,000 people. When you have it, you have a lower waist-hip ratio, you have a lower risk of diabetes, and when you have that mutant messes up the signaling of ALK7. And what that means is that if we develop a drug against ALK7, that may protect against the metabolic consequences of overnutrition. Finally, everything I've talked to you about today about the metabolic consequences of obesity, the insulin resistance, the pro-inflammatory states, all impact greatly on this challenge of our time, COVID-19, its cause of death through the terrible pulmonary pathology. And in my longer talk, you'll be able to see a more detailed exposition of how obesity may lead to the exacerbations of this illness through a range of mechanisms. So thank you for your attention. Enjoy the rest of the meeting.
Well, thank you very much, Stephen. Great start to the meeting. What I really enjoyed about that was the fact that you managed to make such a potentially complex topic remarkably straightforward, and just the ticket. While we're waiting for questions to come flying in, which I suspect they may well, I hope so, I'd just like to ask you one thing, if I may, and that is, we talked about this in the past, treating obesity with hypertension, say, as an analogy, or hypercholesterolemia as an analogy, where the consensus seems to be start early, and the earlier you start, the better. These are things that are potentially driving disease from a very early age. So what about this with the genetic determinants of obesity? They operate from birth. When do you see interventions coming in?
Well, I think that's a great question, John, and a complex one, because obesity, of course, has both environmental and genetic drivers. And I think that the sort of grown-up conversation that we need to have around obesity is the sort of thing that we have done with hypertension. I mean, with hypertension, what we've done is, when I was a junior doctor, the ward I looked after was full of people having hypertensive emergencies, encephalopathy, hypertensive retinopathy, heart failure. That just doesn't happen anymore. Now, how do we make that happen? We made it happen through public health measures of screening, early intervention, low salt encouragement and reduction in salt in legislation in some places in terms of added salt, and the early introduction of effective long-term antihypertensives. And I see a very strong analogy with obesity here. We need to do all the public health intervention. We need to make our environments less obesogenic. We need to help parents not or at least not facilitate their children's genetic predisposition to obesity. But then, in those where we failed, we can't discard the obese. We need to help people who are obese not develop these serious diseases. And now, thankfully, from what we'll hear a bit later, we're now in a new era. We are starting the era of safe and effective therapeutics for obesity. It's been a long struggle. It's been hard to find drugs that are both safe and effective, but I think the next few years will see a development based on the sort of stuff you'll hear later on from John Wilding and others, that we are in a new era. And so I'm very positive that we will have the same sort of approach to obesity as we've taken to hyperlipidemia and indeed to hypertension.
Yeah, great. I've got a question that's come in here. How does this model fit in with the research implicating the microbiome in obesity?
Well, I have to say, I think the microbiome is a fascinating thing, and it's a great area of exploratory science. Some people are totally very excited about the associations of microbiome and various metabolic parameters. I am less so. I'm less convinced by the rigor of the data, and I'm more convinced by some of the negative data, such as those, for example, from beautiful experiments in Holland, obliterating the microbiome with antibiotics over many months and showing no impact on measures of energy balance and insulin sensitivity. So there's a lot of good quality negative data out there that perhaps doesn't get the I mean, it's always hard to get negative data, good publicity, but I'm a cautious. My approach to the microbiome at the moment is highly cautious. So no harm in drinking your kefir and eating your kimchi. I'm sure it probably, but it probably won't obliterate your obesity, at least not on its own.
Yeah. There's another one here. Presumably, carrying a genetic predisposition to obesity has in the past been an advantage in time of relative famine, high activity, etc. There must have been some positive selection in favour of that in the past. If that's the case, are you surprised there isn't a stronger genetic component to obesity at the moment than there actually is?
It's a very good question, and it's something that people always assume. But, for example, we know now what the common variants are in the human genome that associate with increased body mass index. And we know how to look for what's called signatures of selection. There are ways of looking at the genome for saying, that's a selected region. And the striking thing about all the obesity genes is there's no evidence of signature selection at all. They seem to have occurred randomly. And in fact, John Speakman is a great arguer for this. He calls it the drifty genotype rather than the thrifty genotype. There's a great fondness for the idea of the thrifty genotype, i.e. that we evolved to have these genes. But actually, as John points out, during most of our human evolution, we were never threatened with over-calorification. And so our hypothalamus probably drifted between ourselves in a kind of almost irrelevant way until the recent past, when for the first time we've been exposed to more calories available to us than we need. And we're unprepared for that. And therefore, we're variably susceptible to obesity, largely based on stochastic chance. There are some populations probably where there was an evolutionary bottleneck. The Pacific Islanders, Samoans, etc., where perhaps there was a selective advantage for making those very few people who managed to make it to the island on long boat trips, might have been those who carried more heft to start with. But there's very little, it's a lovely idea, but if you apply modern rigorous evidence for the sorts of selection, for example, we see with the sickle cell trait or lactase persistence, etc. You can look at those bits of the genome and say, wow, they're clearly been selected for. None of that is true about the obesity common genome. They just look like random bits of in the genome. So nice idea, but not supported by the data set.
Could you, I've got a question here, really referring to the potential time with racial and ethnic predispositions to obesity in general, and to what extent they're mediated via some of the genetic predispositions you're talking about.
That's another great question. All right, a lot of noise in the background. Could people mute when they're not? I'm just hearing a lot of noise. So there's
1 minute.
sorry, just go back to the ethnic question. Yes, there's indeed a great variation in ethnic susceptibilities to BMI, with some ethnicities, particularly, as I say, Pacific Island individual Pima Indians, for example, being hugely susceptible, and for reasons that we're not entirely yet clear about. One thing that does seem clear is that white Caucasians seem uniquely able to become obese without getting the adverse. We're almost protected compared to almost any other ethnicities from the adverse consequences of obesity.
Great.
It seems possible for us to get morbidly obese and yet have a high proportion of individuals who don't develop the metabolic syndrome or insulin resistance. Of course, many of us do, but the propensity in South Asians, East Asians, Hispanic, South American,
pretty high,
very high, even at modest degrees of obesity, the metabolic syndromes occur dramatically.
Okay, Stephen, I'm going to have to draw you to a halt at that point, I'm afraid. We're on a rather strict time schedule here, but thank you very much for a great talk and very interesting Q&A as well. Many thanks.
My pleasure.
I'm now going to hand over to my co-chair, Professor Derek Yellen, to introduce the next speaker.
Thank you, John. It gives me great pleasure to introduce John Wilding, who's Professor of Medicine at the University of Liverpool. And as this talk we just had before, which was fabulous, we're in for another terrific presentation. So, John, it's over to you.
Hello, my name's John Wilding from the University of Liverpool, and I'm going to talk about whether we've reached the limits for the treatment of obesity with GLP-1 receptor analogues. We know that weight management is difficult. The first thing we have to achieve is, of course, weight loss through diet and physical activity, but the challenge is maintaining that weight loss and preventing weight regain so that we can achieve the long-term benefits of weight loss, including, for example, improvements in diabetes, cardiovascular risk, improving functional impairment, and ultimately improving people's quality of life. The reality, though, is that maintenance of weight loss is challenging, as we can see here from a number of clinical trials where weight loss has been achieved over a year or so, but in the long-term follow-up, we tend to see weight regain. Why is this the case? We know that if we go on a diet, there are physiological changes that tend to push us back towards our previous body weight. These include reductions in the fat hormone leptin that signals appetite to the brain, and also changes in gut hormones such as GLP-1, a satiety hormone, and ghrelin, the hunger hormone, that tend to make us feel hungrier. We also see reductions in energy expenditure that tend to mean that the body tries to conserve energy. As a result, people have tried to look at whether it's possible to help maintain weight loss using pharmacotherapy as an adjunct to diet and exercise. And we currently have 3 pharmacotherapies approved within the UK and the European Union. These include orlistat, the intestinal lipase inhibitor, which is moderately effective but not tolerated because of its GI side effects by some people. The combination of naltrexone and bupropion, a centrally acting agent, which is not widely used and not approved by NICE in the UK. And finally, we have liraglutide 3 milligrams, a GLP-1 receptor analog, which is approved by NICE for use for some people with obesity in the UK. GLP-1 is an interesting molecule. We know that it is used widely for the treatment of diabetes because of its beneficial effects on insulin and glucagon secretion. But it also has important effects on the brain to reduce appetite and is part of the satiety cascade that I described earlier. So if we use GLP-1 receptor analogues as potential treatments, they do seem to have effects on appetite. Here we can see a study using liraglutide at the higher dose of 3 milligrams that is approved for weight management, demonstrating that it is able to reduce energy intake during a test meal situation, but that it does not have effects on energy expenditure. The reduction in energy expenditure here is due to the energy conservation that occurs with weight loss. In clinical trials for the treatment of obesity, liraglutide has been shown to be consistently effective at producing weight loss of, on average, between 5.7 and 8%, compared to much lower percentage weight loss with diet and exercise alone, and that about half to 60% of people are able to achieve clinically relevant weight loss of 5% or more. Can we do better than liraglutide? Well, semaglutide is a weekly GLP-1 receptor analog, and this was tested in the STEP trials. I'm going to focus here on the largest trial in the STEP program, the STEP 1 trial, that randomized people with obesity, without diabetes, and who had not had bariatric surgery or recently used other weight management to treatment with semaglutide or placebo. We can see here that on the background of lifestyle intervention, the follow-up was for 68 weeks, and patients were randomized 2-to-1 with semaglutide or placebo. Let's turn to the results. We can see that in the placebo group, the weight loss was around 2.4%, compared to 14.9% with semaglutide in the intention to treat analysis, and slightly greater weight loss if we look at the 90% or so of patients that maintained on study drug during the course of the trial. Another way of looking at this is to see how many people achieved weight loss of 5% or more. This was achieved by 86% of people with semaglutide 2.4 milligrams, compared to just 32% with placebo. More than 2/3 of people achieved a weight loss of 10%, more than half a weight loss of 15% or more, and nearly 1/3 achieved 20% weight loss with semaglutide in the intention to treat analysis. This was associated with improvements in body composition, as seen here in this sub-study using DEXA to measure body composition, where we see reductions in total fat mass, reductions in lean body mass, compared to no significant change with placebo. This translates into improvements in risk factors and other outcomes. So we see reductions in waist circumference, reductions of 6 millimeters of mercury in systolic blood pressure, and improvements in physical functioning using both the SF-36 and the impact of weight on quality of life scores. We also see improvements in lipid profiles with reductions in total and LDL cholesterol, as well as VLDL cholesterol and triglycerides, and improvement in the protective HDL cholesterol. Interestingly, we also see reductions in inflammation as measured by C-reactive protein. In terms of adverse events, what was seen in the STEP 1 trial was similar to what we expect with GLP-1 receptor analogs, with nausea, diarrhea, vomiting, constipation occurring early during treatment but tending to resolve over time, and a small excess of patients experiencing gallbladder-related disorders, as we expect with any intervention for weight loss. If we look across the STEP program, 4 of these trials have now completed, and we can see pretty consistent results. STEP 1 shown here, STEP 2 in people with diabetes, slightly less weight loss, but nevertheless quite impressive at 9.6%. When we combine semaglutide with intensive behavioral therapy, we see a little bit more weight loss. And in the sustained weight management trial in STEP 4, we actually saw 17.4% weight loss, but of course weight regain when the treatment is stopped, which is of course what we expect with any weight loss medication. Of course, showing reductions in risk factors is all very well, but what's important is reductions in events, and this is being tested in the ongoing SELECT trial, which has now completed randomization of 17,500 people with pre-existing cardiovascular disease to semaglutide or placebo, and with the outcome of 3-point MACE, which will give us some results in about 3 to 4 years' time. Can we do better than just semaglutide? Well, here we see a study with a GLP-1 receptor, GIP receptor analog called tirzepatide in people with diabetes. This is just a 26-week study, but we see very impressive reductions in HbA1c compared to the GLP-1 receptor analog dulaglutide, as well as 11.3 kilograms of weight loss compared to just 2.7 kilograms with dulaglutide. This agent, like others, is associated with nausea, vomiting and diarrhea, but is being tested in a comprehensive phase 3 program. Another possibility is to combine semaglutide with another gut hormone called amylin. And in this 20-week trial, we can see that amylin was associated with a 17.1% weight loss when combined with semaglutide, where 2/3 of people achieved a weight loss of at least 15%. So it looks as though we can now get much closer to the sort of weight loss that we see with bariatric surgery. We're already in the range of the sleeve gastrectomy with semaglutide, but I think with combining GLP-1 receptor analogs with other gut hormones, we may get close to what we see with a Roux-en-Y gastric bypass. So to summarize, I hope I've convinced you that although weight loss with diet and exercise is difficult because of the physiological responses to weight loss, that we can use GLP-1 receptor analogs to support people to maintain and achieve higher weight loss, and that we may even be able to reduce cardiovascular disease if the SELECT trial is successful in showing semaglutide reduces cardiovascular disease in people with obesity and at high risk. We may not have yet reached the limits because we also have the possibility of combining GLP-1 receptor analogs with other gut hormones such as GIP and amylin that may produce even greater weight loss to rival bariatric surgery in the future. Thank you very much for your attention.
Thank you very much for that really terrific presentation, John. Can I just begin by asking a couple of questions? To put things in context, the DPP-4 inhibitors work via inhibiting the breakdown of GLP-1, and yet they have no effect on weight loss per se. Is this due to purely the concentration of the levels of GLP that you get after DPP-4 inhibitors are acting?
I think that's a good question. I think it's probably a little bit of both. I think it's partly because you're only getting a very modest increase in endogenous GLP-1 levels with the DPP-4 inhibitor, so nothing like the sort of powerful pharmacological effect that we see with the GLP-1 receptor analogs. But the other thing is that the GLP-1 receptor analogs are not all quite the same, and some of them seem to have better access to the central nervous system than even probably native GLP-1. And certainly semaglutide and liraglutide, which have this fatty acid attached to them, which contributes to their long half-life and circulation binding, helps them bind albumin in the circulation, but also probably helps access to the areas of the brain that are important in appetite control.
That makes eminent sense. Thank you. Just one more point, really raised by Stephen O'Reilly in his previous talk, where he mentioned chronic treatment with GLP-1 analogs. Stephen made the point of long-term treatment, if you remember, being important. But what is the evidence? How long have we had with treatment with GLP-1 analogs? It hasn't been that long.
You're right that we probably do need to change the way we think about treating obesity to the same way that we would treat dyslipidemia or hypertension. So we think about chronic long-term management. Certainly we have evidence from the doses that are used in diabetes for GLP-1 analogs for people being treated for 4 or 5 years or even longer in clinical trials. And those show cardiovascular benefit, in fact, in people with diabetes. And we also have some evidence from other studies with other weight loss agents that treatment can go on for certainly a number of years. I would think we need to consider these as chronic therapies, much the same as we do other treatments. And of course, the SELECT trial will go on for about 4 years, so that will give us some data on long-term treatment with semaglutide 2.4 milligrams in a high-risk population from a cardiovascular perspective.
Great, we look forward to that then. We've got a question from one of our Stephanie Baldwin, Professor Stephanie Baldwin, who's one of our co-persons here. Stephanie?
I'm not sure, can you see me and hear me, everybody? Yeah, hi. So my question goes along the same line, it's very clinical. Do you envisage us using these drugs very much as a preventative therapy eventually? Because it seems we are using them late at the moment. All the national, international guidelines saying use them when the BMI is very high or there's comorbidity. Would it not be more sensible to use them earlier?
I mean, I think certainly we already have some evidence in people with diabetes that using them earlier is probably better and helps maintain good glucose control for longer. And you could make the same argument for people with obesity, that it's better to treat earlier and therefore reduce the exposure, if you like, to the risk factor, which is, for diabetes and heart disease and so on, which is the obesity. The question then becomes a health economics one, as to what point does it become economically worthwhile using these agents in people with obesity. And I think that we don't yet have the answer to. Certainly from what we know with liraglutide and the way that NICE have looked at that, they're really only approving it for patients with prediabetes and who are at high risk of cardiovascular disease, which is quite a small subgroup of the totality of people living with obesity. Of course, that means that you're only focusing on one aspect of the problems associated with obesity. And if you start bringing in some of the mechanical and mental health issues, then you could argue for earlier treatment from that point of view as well.
Thanks, Stephanie. We've got so many questions coming in. So let me try and join up two questions based on semaglutide. And one is oral semaglutide equally effective as parenteral form? And the other question was, I can't find it now because they just come in so fast. Is this semaglutide trials, were there any trials with oral semaglutide in this regard?
Yeah. So oral semaglutide, as many will know, is already available for treating diabetes. The dose that is used for treating diabetes is 14 milligrams a day. So a much higher total dose needs to be given to get the absorption into the GI tract. And at the 14 milligram dose, the weight loss in people with diabetes is somewhat less than the 1 milligram dose is for treating diabetes. So to get an effective dose that would work in obesity, I think you'd have to push the dose a lot higher. And I don't think that would be either pharmacologically possible or probably not economically worthwhile either. So I don't think the oral version is, in its current form, is going to be useful for obesity treatment.
Just to, as I say, they're coming in fast and furious. And another one here, would GLP-1 receptor analogs be a good causal treatment for metabolic syndrome?
Yeah, that's a great question, and we already have some data on that with liraglutide, and certainly as I showed you, all of the components of metabolic syndrome, so central obesity, hyperglycemia, hypertriglyceridemia, low HDL cholesterol, are all and blood pressure are all effectively lowered with semaglutide treatment. So I would have thought it would be a very excellent treatment for metabolic syndrome, and we will be doing some future analysis of that data from the Step 1 trial, which I'm not able to share yet, but that will be presented at some point in the future.
John wants to come in, but I just want to bring one more question. We've got a little bit extra time, and from all the questions that are coming in are anonymous. I can't give credit to anybody, unfortunately. But one of the questions was, in my experience, when GLP-1 receptor analogs were stopped, there was a marked increase in weight. How can we avoid this?
Well, this comes back to the question about, are these long-term treatments? Of course, if you wouldn't be very surprised if you stopped an antihypertensive and the blood pressure went back up again. And exactly the case is true for obesity treatments. We're not in any way resetting the appetite system other than by pharmacologically controlling it. The only treatment that works long term, but does it by causing permanent alterations in the gut hormones, if you like, is bariatric surgery. And indeed, if you reverse bariatric surgery, people will regain the weight that they've lost, even if they've lost that weight for many, many years.
John, do you want to come in with a question?
Just one quick one, John. We're nearly out of time here. how do you recommend handling dose titration? These are fairly high doses of semaglutide. You might even envisage going higher in the future, I don't know, but how do you think we approach that practically?
Yeah, so the way this was done in the trials was that patients were titrated every 4 weeks. So it took 16 weeks to work up to the 2.4 milligram dose. I think and that will be the recommendation, I'm sure, when it becomes available. The reality, and we've certainly found this when we're using liraglutide at the 3 milligram dose, is that some people will actually get quite a good therapeutic response at a lower dose and may choose to continue at that lower dose. It's going to be down to the individual, but that's probably not the way that the drug is going to be recommended to use. But in practical terms, that's probably the easiest way to do it, is to titrate and stop.
Great.
Yeah.
20 seconds left. And just a yes or no answer to the final question. I'm trying to get as many people in as possible. In this person's experience, when GLP-1 was led to a marked increase in weight when it was stopped, how can we avoid this?
Well, the best thing is to continue the treatment long term. Because
Yeah. Sorry, you know something? I've just repeated a question I've asked you, but I was just testing you, John, to see if you were... Sorry about that. Look, I'm getting signals from all over the place. We're going to have to stop. Can we thank you so much? We could literally go on for 20 minutes with all the questions. Thank you, everybody, for sending in your questions. That really is fantastic.
Thank you.
Hello. I want to begin by thanking Professors Yellen and Cunningham for inviting me to participate in this meeting. My name is Mansour Hussain, and I'm Professor of Medicine at the University of Toronto and an attending cardiologist at the Toronto General Hospital. I've been asked to talk about GLP-1 analogs and whether we've reached the limits in cardiovascular medicine. The answer to that is most certainly no, and the three take-home messages are: I believe these agents remain underutilized in patients who could benefit from them. I believe there are potential additive benefits using them together with SGLT2 inhibitors. And there are new GLP-1 analogs that have GIP analog function, which may be even more potent cardiovascular medications. Here are my disclosures. Let's begin with some epidemiology. This is a plot that looks at the event rate per 100,000 adult patients in the United States between 1990 and 2010. You'll appreciate that there's been a slight fall in the incidence of acute myocardial infarction, whereas that of stroke, amputation, and end-stage renal disease have remained flat in the general adult population. In patients with type 2 diabetes, the event rates have been falling of MI, stroke, and to a lesser extent, amputation and end-stage renal disease. And on the surface, this may look like good news, but at the top you'll appreciate that the number of patients who have self-identified with diabetes has tripled from 6.5 million in 1990 to almost 21 million in 2010. You'll also appreciate that the incidence rate is many, many-fold higher than that in the adult population. As such, there remains a significant cardiovascular disease and risk burden in patients with type 2 diabetes. And how do we begin to address that? Well, in this analysis by Ray and colleagues published over a decade ago in The Lancet, where they looked at the benefits of treating risk factors in patients with type 2 diabetes, we learned that reducing systolic blood pressure and reducing LDL cholesterol had significant impacts. In that era, treating hemoglobin A1C, in other words, better, tighter glycemic control, did not translate into significant improvements. But this was the era of traditional glucose-lowering medications: metformin, sulfonylureas, insulin, PPAR gamma agonists, and just emerging at that time, DPP-4 inhibitors. We didn't have what we have now: two classes of drugs, SGLT2 inhibitors and GLP-1 receptor agonists, that have significant cardiovascular benefits. As Darren McGuire summarizes in this meta-analysis, the reduction of MACE, that is CV death, non-fatal MI, and stroke, in patients with type 2 diabetes at high risk of cardiovascular disease is significant in those randomized to receive an SGLT2 inhibitor. A 10% reduction in these 47,000 patients so randomized. When we look at CV death and heart failure for hospitalization for heart failure, they're even more impressive, 15% reduction and 32% reduction respectively. Now let's look at the cardiovascular outcome trials of GLP-1 receptor agonists. There have been 7 trials that show with the same 3-point MACE a 13% reduction in 56,000 patients. If I look at CV death, there's a 12% reduction. And if I look at hospitalization for heart failure, there's a very reassuring 9% reduction. And then, if we look at only those GLP-1 receptor agonists that are based on human GLP-1, not the lizard exenatide molecule, it's a 17% reduction in 3-component MACE, arguably more potent in these endpoints than SGLT2 inhibitors. Specifically, stroke is a very consistent result in these cardiovascular outcome trials, with an overall 16% reduction. I'll remind you that this is more potent than any other of the components I've already discussed. This has resulted, of course, in both in Europe and North America, and now globally, all of the guidelines identifying the benefits of these agents. In patients with type 2 diabetes, with established CVD, or at high risk of CVD, we should be using an SGLT2 inhibitor or a GLP-1 receptor agonists, even as first-line therapy. And then in patients who are not at glycemic target or who are already on background metformin therapy, the same recommendation has been made, importantly, irrespective of A1C. So are we using these drugs? Well, in this Scottish registry of almost 250,000 patients, where the background demographics are very similar to those cardiovascular outcome trials, 32% of the patients had established CVD in this registry. And you'll appreciate here pretty high uses of antihypertensive medication and anti-lipid medications, appropriate treatment of important cardiovascular risk factors. But when it comes to the use of diabetes medications, less than 3% of those patients without CVD were on a GLP-1 or an SGLT2 inhibitor. That might be acceptable, but what about those patients with CVD? Again, surprisingly, less than 3% of patients are on drugs with proven benefits in this population. What about combining SGLT2 inhibitors with GLP-1 receptor agonists? This is a retrospective analysis published in abstract form at the ADA, looking at about 12,500 patients propensity matched with patients taking sulfonylurea. Those on background GLP-1 receptor agonists were either taking SGLT2 inhibitors or sulfonylurea. And you'll appreciate a 25 to 30% reduction in CV events and a 35 to 40% reduction in heart failure hospitalization, suggesting in this retrospective analysis that there's additional benefit of SGLT2 inhibitors even in patients already on GLP-1 receptor agonists. Let me end with these exciting data. There are now agents that are GLP-1 receptor agonists, but also GIP receptor agonists. Tirzepatide is one such agent. As these plots show, dose-response curves in cyclic AMP accumulation in cells are comparable to that of native GIP, somewhat less potent with regards to activating the GLP-1 receptor. But what about a head-to-head comparison of this agent versus GLP-1 receptor agonist semaglutide? The SURPASS-2 study looked at people inadequately controlled on background metformin and randomized them to 3 different doses of tirzepatide once weekly versus semaglutide 1 milligram once weekly. You'll appreciate more potent A1C reduction, more potent weight loss, and a higher percentage of patients achieving glycemic target. To summarize, there are high rates of CVD that remain a major burden in patients with type 2 diabetes, and drugs proven to reduce these risks are not being used in these patients. GLP-1 receptor agonist cardiovascular outcome trials clearly identify benefit in patients with CVD or at high risk of CVD, and combining the two classes of drugs may be even better. One of the more consistent and robust effects of GLP-1 appears to be on stroke. We don't yet know if the remarkable metabolic effects of these dual agents or twin incretins will also have cardiovascular benefits. So in answer to the question, have the limits been reached? The answer is no. We have much further to go. Thank you very much.
Thank you, Mansoor. Great talk, as expected, just what we wanted. There are plenty of questions around for you. I'm going to merge two together, because they're broadly touching the same issue, and that is how you use these drugs alongside SGLT2 inhibitors. One of the drugs is, which would you use first as a general guideline, SGLT2 inhibitor or GLP analog, from a cardiologist, that is, and then the specific instance where there's a history of heart failure versus, and also a history of established cardiovascular disease, I presume atherosclerotic cardiovascular disease. Which one would you come in with first there?
Yeah, thanks. Those are both really excellent practical questions. I think we're blessed in cardiology to have access to these two classes of drugs. They're both excellent potential first choices for an individual with underlying cardiovascular disease. I'm going to take the first question first, which is, as a general cardiologist, which one would you use first? It has been easier to prescribe because of its oral once daily nature, the SGLT2 inhibitor, until the availability now of an oral GLP-1 receptor agonist once daily as well. But myself, I use a lot of injectable once weekly GLP-1 receptor agonists, and they're really quite easy to use once the patients get on them, with great effects. The tougher second question about a patient with heart failure who also has established atherosclerotic coronary disease, in other words, that dichotomy of preferring an SGLT2 inhibitor for heart failure and a GLP-1 receptor agonist for atherothrombotic disease, is in the same patient. I think I would be happy starting with either one first. And importantly, the safety of the GLP-1 receptor agonists in the presence of everything except advanced heart failure gives me confidence in being able to do that. Generally, because of their ease of use, I have started SGLT2 inhibitors first, but in particularly the obese patient who's already on, let's say, injectable insulin, I have also gone to injectable GLP-1. Now the oral GLP-1s, I think, are going to change the landscape.
Okay, so that was a sort of either-or scenario that the questions there posed. What about both together, early on in, as it were, the drug progression here in practical terms?
Yeah, absolutely. You know, unfortunately, we don't have a clinical trial that has directly demonstrated that combination therapy with both classes of drugs is superior to either class alone. I'm not sure we ever will have one, but there's lots of logic in using them both together. Gets expensive, I understand that, but there remain people whose A1C is not controlled on one agent alone, and I use them in combination. And there remain people who have residual cardiovascular risk despite one agent, and one could envision using both of them together. Lots of good metabolic reasons, and I believe cardioprotective reasons to use them together.
There's another question here that says, why do you think we're so reticent about using these drugs, and what can be done to improve uptake? I mean, this touches on the general lament from people like yourself and from pharma that these drugs are taken up at a relatively low rate. Cost is obviously part of it. I mean, do you think metformin has anything to add once you've started one of these drugs, for example? Are we looking at it the wrong way around?
Yeah, no, I mean, metformin is a great drug. We've taken full advantage of it for 5 decades. And But the data on metformin's ability to reduce cardiovascular outcomes in the modern era is scarce, right? It comes from long-term follow-up of UKPDS in a few hundred patients. And therefore, how does it compare to the modern era data, which is very robust and very strong? And to the argument that the modern trials were done on background metformin therapy, for the most part, that's an accurate statement, but there now have been many analyses looking at even in patients who are not on metformin, unable to take metformin, or the metformin had been stopped, the benefit remains with both SGLT2 inhibitors and the GLP-1 receptor agonists. So I do believe we underutilize them, should move them up the stream, starting them even potentially first line. And I think there's good clinical evidence to support doing that. I think the only hesitancy has been cost and unfamiliarity with any new class of drug, which that knowledge translation gap, which sometimes is years, but I think it's starting to shorten for both these classes.
There's another question here touching on the GIP-1, GLP-1 combination, and some evidence that this works very nicely, certainly in weight reduction. And you alluded to this in your talk as well. Where do you think that's going?
I think it's tremendously exciting. This the agent I spoke of, tirzepatide, is the first. An entire program, the SURPASS program, is built around it, as I touched on, and I believe that remains to be seen how they'll do with the CVOTs, which are underway, but very exciting, very profound benefit. I frankly, personally, was a bit surprised, didn't expect the GIP side of the equation to have so much additional benefit, but makes sense once you see the data.
Another question here obviously comes from the UK because it refers to one of the advisory bodies, or the British National Formulary here, which is not prescriptive but talks about prescriptions, and it advises that we don't use SGLT2 inhibitors in severe fatty liver scenarios, and yet the question points out that many of those patients are just the patients you might want to give an SGLT2 inhibitor to. Any thoughts on that?
I'll confess I don't know specifically why the guidance against fatty liver disease, so I'm not familiar with any data that would give that guidance. I mean, the only thing I can surmise is that the SGLT2 inhibitors don't have the best lipid profile in people taking them, whereas GLP-1 receptor agonists have a beneficial effect on lipid profile, and there are some intriguing data on fatty liver disease with that class as well. So in a very obese patient, they often have very fatty livers. And so I will usually choose a GLP-1 receptor agonist first line in an obese diabetic with cardiovascular disease.
Yeah. Okay, thank you. Derek, you had a question?
Yeah, Mansour, if I remember correctly in the previous talks, semaglutide oral is not very effective in terms of weight loss. Would it still be effective in everything else it's meant to do? And what's your feelings here? Is it just because the way the gut works, the way the tablet is manufactured, et cetera, that it won't work as well as an injectable?
So thanks, Derek. An important question that we're often asked. Very important to keep in mind that semaglutide oral and semaglutide subcutaneous are the same molecule. It really is the route of delivery, and my own belief is it's the bioavailability.
Okay.
It's a remarkable feat to have developed the ability to absorb a protein molecule from the gut, protected against the acidity of the hostile environment of the stomach. But there is variability, the daily dosing. But I would say that there is weight loss. The magnitude of the weight loss of a 14 milligram semaglutide oral daily dose versus a 1 milligram subcutaneous weekly dose is lower overall, but there is weight loss. And for those patients who don't want to go the injectable route, it now is a great option to have an oral
And if I could
tablet.
just interrupt you, and the side effect profile for either, is there any different?
Not really. They both have the same GI side effects that all the GLP-1 receptor agonists have, the same metabolic effects, the same heart rate increase of 2 to 4 beats per minute. Everything that we see with the injectables, we see with the orals. There's not more oral side effects because you're taking there's not more GI side effects because you're taking the tablet orally.
Okay.
The last quick question, it's actually a question that begs a long answer, so I'll just ask you to keep it short, and that is cost-benefit analyses with these drugs. They are pricey. That's one of the reasons for slow uptake.
Yeah, they clearly are pricey, but if you look at the number of events that they prevent, the hospitalizations that they prevent, the down-term sequelae that they prevent, their cost effectiveness will be in line with many therapies already accepted and underway. And so I think, however, the regulators and payers have to make those decisions and go through the data as they accumulate.
Yeah. Okay, I think that is going to bring this to a halt, and thank you very much indeed for fantastic talk. Sorry about the failure to introduce you properly at the beginning. Your reputation nevertheless can withstand that, and a most interesting Q&A as well. Thanks again.
Thanks, Matt.
Thanks for having me.
I'm going to hand over to my co-chairman now, Derek Yellen, to introduce the next section.
Thank you very much, John. So really, that's the end of our first session, and now it's a pleasure to bring you our industry symposium, which is sponsored by Amgen, and it's 30 minutes duration and entitled Cardiovascular Risk Management in Diabetes and Chronic Kidney Disease.
Welcome to this symposium, Cardiovascular Risk Management in Diabetes and Chronic Kidney Disease. I'm John Cunningham, and I'm a Professor of Nephrology at University College London and at the Royal Free Hospital, also in London. In this session, we are going to be sharing perspectives on recent guideline recommendations and examining the recent clinical data on the management of CV risk in high-risk populations of interest. The full version of this symposium, which is also going to include my presentation entitled Convergence of Metabolic Bone Disease, CKD, and the Cardiovascular System, Multiple Goals when Treating Hyperparathyroidism, and also a subsequent Q&A session after that, is available on demand on the Congress's website now. I would now like to introduce my co-presenter, Professor Ray, President of the European Atherosclerosis Society, Professor of Public Health and Honorary Consultant Cardiologist at Imperial College London, to begin his presentation, which will be entitled PCSK9 Inhibitors and CVD Prevention, focused on high-risk patient groups, CKD, diabetes, and post-ACS patients. Professor Ray.
Thank you, John, for the kind introduction. So it's a pleasure to be given this talk today. My name is Kaushik Ray from Imperial College London, and the title of this presentation is PCSK9 Inhibitors in CVD Event Prevention. Really, the focus is on high-risk patients because these are individuals that we know derive the greatest benefits from any intervention. And we're going to look in a bit more detail at patients with chronic kidney disease, diabetes, and the post-ACS patients. But before we do that, there's really a reminder on this slide of why we think about lipid-lowering therapy. So there is this misconception that we're only interested in lipid-lowering therapy in people with elevated lipids. The name of the game is to reduce risk. And so in the European guidelines published in 2019, as before, we don't separate primary and secondary prevention patients. We try to first put these individuals into different risk categories where we're trying to estimate the future risk of cardiovascular events, because that then guides us towards appropriate lipid-lowering therapy to essentially match or achieve sufficient LDL reductions for level of risk. So there are broadly 4 groups that we define. Those individuals that we classify at very high risk, and here these may be people with already established disease. But you may have high risk not because you've got established cardiovascular disease, but you've got high risk conditions such as diabetes with additional risk factors that push your event rate up, or things like chronic kidney disease with eGFR less than 30, for example, or you're a familial hypercholesterolemia patient where now, because of an excess or a very high level of an individual risk factor, your 10-year risk is really very high. And then there are those individuals that don't fall into those 3 categories who, through combinations of multiple factors, have a 10-year risk of dying from cardiovascular disease of more than 10% using a risk algorithm. And then we've got high risk and moderate risk and low risk patients. So now we no longer have patients with established cardiovascular disease. What we're looking at are now high risk conditions, perhaps with fewer additional factors, as a way to now quantify the level of absolute risk in these individuals. So, having done that and first assess risk and put people into these different categories, the next aim is to titrate or match LDL to level of risk. And what this slide shows you are the 2016 and the 2019 LDL goals. And you'll see that in lower risk patients, we don't need such a stringent or such a low LDL cholesterol level. For those individuals at very high risk or high risk, we want to achieve both a percentage reduction of 50% and also a certain level of LDL cholesterol. And previously, these 2 groups were 2.6 and 1.8 millimoles. Between 2016 and 2019, what happened is, with emerging evidence from a number of different therapeutic approaches, where we add treatments on top of statins, we can see that we achieve much lower LDL cholesterol levels, and that seems to translate into further risk reductions. And as a result, the iteration in 2019 advocated new lower goals in at least 3 of those categories. Now, that's got some practical implications that I'm going to discuss and show you in the next couple of slides. And one of those categories that is a new one that we didn't have before is this concept of disease progression or rapidly progressing disease within a 2-year cycle, where in addition to a 50% reduction in LDL, the recommendation to achieve an LDL of below 1 millimole. So guidelines are well and good, but what is it that we're actually doing? So this is data from the Da Vinci registry, and this enrolled approximately 6,000 individuals across 18 European countries. And what we set out to do in this study was to answer the questions that when you treat those 4 different types of patients, what type of lipid modification therapy do you use, and what is it that you achieve? Now, half our patients were primary prevention and half were secondary prevention, and approximately 3/4 of our sites came from secondary care, but we also had good representation from primary care as well to study those patients. So the answer to the first question is, in Europe, when we manage those 4 different risk categories, our main lipid-lowering regimen is actually statin monotherapy, with about 84% of our patients overall being given that regimen. Now, the majority of that is in the form of moderate intensity statin, with about 52%. So what you can see is that we are very different from hypertension, where combination therapy has been used for a long time now. And here we can see that the use of ezetimibe in combination with statins is about 9%, and PCSK9 inhibitors in combination with another oral agent is only about 1%. And what this means is, on the right-hand side, if we were trying to attain those older, relatively easy to reach goals, or easier to reach goals in 3 categories with a monotherapy-based approach, we'd be successful in just over 50%. But when we change those goalposts in 3 of those categories to new lower goals, that monotherapy-based approach is really going to be effective only in 1 in 3 of our patients. And we can tease that out in a bit more detail. So we all agree that those people with established cardiovascular disease have the highest event rate. We can see from the pie chart on the left that use of moderate and high intensity statins are better, and particularly high intensity statins is just under 40%, 38%. But again, we need to think about moving from high intensity statins to high intensity lipid lowering regimens. And you can see in the dark boxes on the right hand side, when the goals in this patient population were 1.8, as you would predict, with increasing potency of lipid lowering regimen, starting first with low intensity statins, gradually through the increasing potency of statins, then moving to combination potent lipid lowering regimens, the biggest reduction or the greatest proportion of individuals achieving those goals is with combination therapy, and mostly with a MAB on top, a statin or an oral agent. Now, as soon as those goalposts shift, and that's shown in the shaded boxes, about 1 in 5, even with combination therapy with ezetimibe, is going to be able to get to 1 in 4. So if we are going to aim for 1.4, then the premise is we will have to use more monoclonal antibodies in addition to an oral agent, because those 2 drug combinations appear to get about 2/3 of our patients to goal. The same is true when we look at primary prevention. So at the top are the easiest to reach LDL goals, so low risk and moderate risk. And if we just optimize the statins, the vast majority are going to get to goal. Now, remember, for high-risk patients, irrespective of primary or secondary prevention, the goals are still the same in those groups. And the new goals are 1.8 for high risk and 1.4 for high risk primary prevention. And again, the same thing that we observed with the secondary prevention patients is true, that if you change the goalpost towards a lower LDL goal, we're going to have to think about combination therapy. So the new mantra is really intensive lipid lowering rather than intensive statin therapy. So let's look now at some of the patient populations where there perhaps is some of the highest burden of cardiovascular disease. And so let's start with looking at chronic kidney disease. And we've been familiar with these data for a while now, that individuals with chronic kidney disease, particularly with declining EGFR, CKD3 EGFRs below 60, then there is this really curvilinear relationship, hockey stick appearance, if you will, with things like all-cause mortality. And then you've got albumin to creatinine ratio on the right-hand side, as well as EGFR. So those patients at highest risk are those with both the lowest EGFR and the highest levels of proteinuria. And what we can see from lipid-lowering trials, so remember the Fourier trial was a population with established cardiovascular disease, but there were patients with different degrees of renal dysfunction. And you can see in red that in the placebo group, the event rates range from 16.1% Kaplan-Meier rates to 12.2%, depending upon level of renal function. And there have been some questions about, well, does lipid-lowering therapy add value? Can it reduce the risk of cardiovascular events? And what you've got to be a little bit careful about is that when we break these down into these multiple different groups, we don't necessarily have enough power for individual subgroups. But what we can see here is with the p-value for interaction, that the addition of lipid-lowering therapy with the addition of a PCSK9 inhibitor on top of a statin seems to provide relatively consistent benefits across the board, irrespective of degree of renal function. And we can look at that in a bit more detail with this spline plot. So in blue is that curvilinear relationship between EGFR and risk of cardiovascular events. And you can see that whole line is pushed further south, and it's lower irrespective of category of renal function. So in people with ASCVD with renal dysfunction, this is potentially going to be a good option to further attenuate cardiovascular risk. So the next question is, well, we're taught at medical school to be a bit more careful in certain groups of patients. So what is the safety of the monoclonals? And here on the left-hand side, you can see in 4,500 individuals with CKD stage 3 or greater, that the incidence of various adverse events, and these are listed, and you can see that they are virtually indistinguishable between evolocumab and placebo. So what about patients with diabetes? So that's another group. We know that the prevalence of diabetes is increasing. Patients with cardiovascular disease, as many as a quarter to a third in ACS trials, have diabetes. So let's look at life years lost. This is not the same as looking at relative risk, so it's another way of looking at it. So what does this slide show? Well, it tells you that if you have diabetes alone and you're age 40, you're going to lose about half a decade of life. If you've got some presentation of vascular disease, unfortunately, already by the age of 40, and you happen to have diabetes, you're going to lose a decade and a half of life. So these are life years lost. This is life expectancy, if you like. So this means that younger patients with diabetes have to be treated much more aggressively to gain those life years lost, particularly when vascular disease is present. And we know from data from the cholesterol treatment trialists that those individuals with diabetes gain, in proportional terms, i.e. relative terms, per 1 millimole lowering, exactly the same benefit in terms of a lower risk of cardiovascular events as those without. And individuals with diabetes may actually, over time, gain more absolute benefits because their baseline risk is higher. And this really doesn't matter what your endpoint is that you are looking at. So this was an analysis that I published from Odyssey Outcomes. This was a post-ACS patient population. About 1/3 of our patients had diabetes, 1/3 pre-diabetes, and 1/3 normoglycemia. Our patients overall at baseline, this is the placebo, are actually pretty well treated, good use of high-intensity statins. But the average baseline LDL cholesterol in this trial, irrespective of diabetes status, is around about 2 or so millimoles per liter. So in that situation, you can see the excess risk that the presence of diabetes carries when accompanied by an ACS event. There's this real almost doubling in the risk of major cardiovascular events, and you can look at individual components. So even though the benefit of a PCSK9 inhibitor, in this case alirocumab in this trial, gave you similar absolute reductions in LDL cholesterol, and that absolute reduction translates on the left-hand side into similar relative benefits. But because the people with diabetes have a higher risk, they derive twice the absolute benefit. So a person with ACS with diabetes is going to benefit. You're going to prevent twice as many events in that population than you are in those without diabetes. So it's another way of identifying that high-risk patient. And finally, let's finish with acute coronary syndrome. So acute coronary syndromes are really important because they have the highest risk of all. But there is really this curvilinear relationship. So we get this up spike of a lot of events occurring very early and up front. And then largely, if you survive that period, the event rate plateaus out and you become a bit more like the bottom line, which is the stable coronary disease patient with a steady accrual of event rates. All of those early trials of statins really excluded the first 6 months after an ACS event. So if you like, you had to survive ACS and then get your low or moderate intensity statin. Now, we were able to take that concept further. And again, this is some work I did over 15 years ago. And this shows you that when you start a high intensity statin in hospital compared to what was the standard of care, which was low or moderate intensity statin, you actually achieve statistical benefit within 30 days of ACS. And that's largely why we were putting people on high intensity statins at hospital discharge. And overall, you'd see this curve separation and about a 24% relative risk reduction. So the next question is, if that's good, then can I do better with further add-on therapy? And this is the Odyssey outcome trial, which is a slightly different design to prove it, which I showed you on the previous slide, because here there is an LDL entrance threshold. So you have your ACS, we stabilize the background statins, and if your LDLs are above 1.8, then you can be randomized to placebo or alirocumab. So in this trial, as powered, it was able to show with the treat to target approach that you could achieve through additional LDL reduction, so getting people down, for example, to about 1.2, you're able to achieve a 15% relative risk reduction in risk of cardiovascular events. We've also got some data in the Fourier trial that corroborates these findings. Fourier was largely a stable coronary disease patient population, but there were some people who had a history of a recent MI, so defined in the last year before randomization. And there were those people that had a remote MI. And what you can see on the left hand and the right hand side are the treatment effects overall. Now, the p-value for interaction between the relative benefits is not statistically significant, so that's probably a more accurate representation of relative and treatment benefits. But what you can see is that those people that have had an event in the last year, the placebo event rate is 17.2% compared to a remote MI where it's about 14.4%. So this also shows you that this is a group that derive, when we think about starting additional lipid lowering early, they get about a 3.7% absolute risk reduction compared to those people who largely are going to be survivors, where the benefit is about 1.1%. So you've got this real consistency of the relative benefit, but then the slide really reinforces why the ACS patient should be also prioritized. So really putting all of these together, what you can see is that the ESC/EAS guidelines now focus on getting LDLs to level of risk and target and goals. And that's shown on the left-hand side. And we have an algorithm starting with statins, adding in ezetimibe, and then going to a PCSK9 inhibitor. And the rationale for this approach is largely driven by cost rather than anything else. Where are we using MABs in Europe? And this is another study. This is an open label registry in Europe. So what we can see from the Hayman's data is that when we look at the early adopters and those people using evolocumab in Europe, that the LDL at baseline, or the entry criteria that we are giving these patients, evolocumab, is an LDL of approximately 4 millimoles per liter. And you can see that just like the trials, when we give people this drug, we get approximately 58 to 60% lowering in LDL cholesterol. And this is maintained over a period of time. But just as we observed with the Da Vinci data, background or combination therapy really determines what goals you achieve. So on the right-hand side, you can see with this approach in the patients in the Hayman registry, what proportion of patients achieve LDL cholesterols in dark blue below 1.8, and what proportion achieve levels below 1.4. And if we break that data down by with or without additional background oral lipid lowering agents, you can see actually the majority of your patients will reach goals, those new lower goals, when you use combination therapy, so 67%. But if you use a MAB just as monotherapy, we are getting about 43% of our patients to goal. So this really reinforces the importance of combination therapy when we want to achieve those really low LDL cholesterol levels. We can look at that in a bit more detail in this simulation. So starting with the Da Vinci data, we can see that moderate intensity statin achieved an LDL of about 2.3. Now we know when we double the dose of statins, we get only another 6% lowering. So high intensity statins, we observed that the LDL cholesterol gave you, or the LDL cholesterol was 2.16, so roughly 6% lower. If we were to optimize those pathways that I've talked about, we could add in ezetimibe next, and that would get us to those old goals, because our LDL on average would be about 1.62, but that would still be above the new goals of 1.4. And what really determines whether or not you get to 1.4 is the addition of monoclonal antibodies with or without that ezetimibe step. So really that is a key take-home message, that for really low LDL cholesterol levels, that addition of a PCSK9 directed therapy with a MAB on top of an oral agent will get the majority of our patients to goal. So this is really the implementation gap. 1 in 5 patients gets to the 2019 goals, and we know from Da Vinci that only 1% of the patients in Europe are using combination therapy with a MAB. And Heyman's would suggest that we're actually starting these patients with really high LDL levels. So what we probably have to try and think about is using those, not at those extremes, but earlier on, if we're going to get most of our patients to goal, because at the moment we're just picking out those outliers. So with that, I would like to hand back to John for the Q&As.
Thank you very much, Professor Ray. A very interesting and informative talk. We'll move now straight on to a few questions, if I may. First one I've got is there any evidence that now we can lower lipids so intensively and effectively that we can actually reverse established disease, or do we just stop the clock?
Thank you, John. That's a good question. So firstly, using lipid-lowering therapy, that first-line agents, brings cholesterol levels down sufficiently to slow and halt progression. When we start to achieve LDL cholesterol levels below 1.8 millimoles, we would then start to see consistent regression. Now, that is more likely with combination therapy, where a second drug is added on top of statins, because you're more likely to achieve very low levels.
Yeah, okay, so that's very important. Second question I've got concerns the duration of risk exposure and how one uses that to determine thresholds. We tend to come in late in the disease, and these therapies, of course, raise the possibility of dramatic interventions much earlier on. Any thoughts on that?
Yes, and our healthcare systems focus on treating disease, not preserving health. So one of the things that we will have to do, because we won't have randomized trial data from younger patients and early in life, is to use genetic data. So using Mendelian randomization to look at risk calculators that will be able to look at a lifetime of risk, but also be able to tell you about duration of exposure. So if you were to change blood pressure, LDL cholesterols, for example, early in life, you'd gain the cumulative benefits from those interventions, and you wouldn't need to actually reduce LDL or blood pressure, for example, that much. Now, if you encounter the same patient later on, that intervention is going to be much greater because you've missed many more years of exposure. So that's how those risk calculators will work, and we'll have those published later on this year.
Yeah, that indeed would be something of a new era, wouldn't it? Very interesting. In terms of the choice of therapy to lower LDL cholesterol, given that you achieve a particular target, does it matter how you achieve that target?
No, it doesn't, because we can start by looking at nature, and we can look at, again, genetic data simulating the drug target. And what they tell us is that when you achieve the same absolute difference in LDL cholesterol, you achieve the same benefit. So nature really doesn't care how you achieve it. And that means we can add on different treatments to achieve the desirable level of LDL for level of risk. And when we do the same thing with trials, two things that you have to do is standardize for the duration of treatment. So is it the first year of treatment, the second year, or combination of those? And if you standardize for LDL difference, you again get the same benefit irrespective of whether it's a PCSK9 inhibitor, ezetimibe, or a statin.
Yeah, okay. And the last question touches vaguely on that, and that is, do you think these putative pleiotropic effects of statins translate to other lipid-lowering therapies, in particular PCSK9 treatments?
Yeah, so I think the statin PCSK9 comparison is an important one, because statins will also lower CRP. PCSK9 inhibitors will lower Lp(a). Now, if you standardize for LDL difference, then the benefits for year of exposure and per unit change in LDL is identical, which means that even though there may be those other biological effects demonstrated, clinically and at a population level, they're probably not really clinically relevant.
Well, time is getting tight. So I will now like to thank Professor Ray and all of you for joining us today. I hope that you found this symposium an informative and worthwhile experience. Please remember that the full version of this symposium, which will include my presentation also, which is entitled Convergence of Metabolic Bone Disease, CKD and the Cardiovascular System, multiple goals when treating hyperparathyroidism, and the subsequent Q&A system after that will be available on demand on the Congress's website from this moment on, from now. Thank you very much again, and goodbye.
Good afternoon, everyone. Our next session is a very much cardiological one, and I will be sharing this with Professor Brian Rayner. You will notice in your program that Professor Libby was meant to chair this, and he's joining us very briefly and will explain why he's passing on this duty to me. Thank you, Peter.
Great. Well, it's wonderful to participate again in cardiology, diabetes, nephrology at the limits. I've been a stalwart attendee and participant, and I will be attending every session of this meeting, except I was scheduled in my day job for a meeting that I cannot avoid at this very hour. So I'm delighted that Stephanie Baldeweg is going to be able to be an able substitute for me. And I'm going to turn it over to my co-chairman, Brian Rayner, and I thank the audience and the speakers for their indulgence.
Thank you, Peter. I'm Brian Rayner. I'm a senior scholar at the University of Cape Town and ex-professor of nephrology. And it gives me great pleasure to introduce Professor Maurice Brown, who's professor of endocrine hypertension at Barts and the London School of Medicine. He's a major researcher in the field of hypertension and was part of the Pathway program of 3 trials on patients with hypertension. These were landmark studies. But on this occasion, he's going to talk on a tale of new variants causing hypertension at the limits of detection, selection, and survival. Professor Maurice Brown, thank you.
Thank you, Derek and John, for asking me to speak again at this prestigious meeting. I look back at pleasure at many of the previous ones, and for instance, the picture at the top right-hand of the slide shows a visit to University of Cape Town with the foothills of Table Mountain in the background. My talk today illustrates that exceptions are of exceptional interest, and we'll be talking about distributions mainly of plasma renin. And this is real data that we measured in almost 1,000 patients, and allows us to define the 2 tails of a distribution. And my talk today concentrates on the low renin end, where hypertension is due to excess salt, and in particular due to primary aldosteronism. To define that, I show you this diagram in which renin is secreted from the kidneys, and as well as stimulating vasoconstriction via angiotensin, also stimulates the production of aldosterone from the adrenal glands. And when these 2 parts of the system are disconnected, for instance, when there is a tumor in one of the adrenal glands, this results in autonomous production of aldosterone or primary aldosteronism. It's over 60 years since Jeremy Conn first described the condition, which used to be called Conn syndrome, and much has happened in the interval. But the techniques which we use today for diagnosis and for surgery are still largely invasive, and the adrenal vein sampling in surgery is a deterrent to patients to come forward. Fewer than 1% of patients are currently diagnosed, and there is an incentive to a better understanding and molecular knowledge about primary aldosteronism to improve what is available. In the last few years, we have been testing whether metomidate PET-CT, a ligand which homes in on the enzyme which makes aldosterone, is an alternative to adrenal vein sampling. In a study of 140 patients, we now have the answer. The box in the middle shows the number of patients who were positive by either both techniques, the 34 in the yellow box, or by one only of the techniques, the blue and the green boxes. So roughly 2/3 of patients overall do lateralize and proceed to surgery. And the results from the patient's cure from either primary aldosteronism and or hypertension shows that there is no diminution in accuracy by having the non-invasive technique, and indeed it met the preset non-inferiority margin and on all counts was nominally slightly superior to adrenal vein sampling in its accuracy of detection. So that's good news. An additional application of metomidate PET-CT is our ability to localize as well as lateralize and release the power of radiofrequency ablation. If one looks at a sagittal view, it becomes apparent that the left adrenal sits very close to the stomach with scarcely a centimeter of clear pathway in between. And with an ultrasound probe in the stomach, especially in the hands of Steve Pereira, it is possible to, under ultrasound guidance, advance a needle into the adenoma, both to take tissue and to ablate the adenoma. The slide here shows 3 of the early patients in the study, the fabulous study funded by the British Heart Foundation, and shows that in each case, a hot adenoma on the top row becomes cold after the radiofrequency ablation procedure. This is the normal bifurcation in the middle patient. And these patients are also cured biochemically and clinically. So very promising, but still a way to go in this study. So lastly, the genotyping and what we can hope from this. Over the last 10 years, it has become apparent that 80 to 90% of the adenomas have a gain-of-function mutation in one of or other of these 4 main genes. And in this prospective study, we're able to look at which of these is most likely to predict complete cure of hypertension and whether there is ethnic variation in their prevalence. On the left-hand side here, you can see that the KCNJ5 mutation, the first one to be discovered by Rick Lifton in 2011, is the commonest in white patients in blue, whereas the calcium channel mutation, which we discovered in 2013, is commoner in black patients. If I remove from this slide the patients who were not completely cured of hypertension, we are left mainly with the KCNJ5 and GNAQ, as you can see on the right-hand side of the slide. And when in a multiple regression analysis, I correct for gender and age, other factors known to influence likelihood of cure, you can see that it's the KCNJ5 genotype, which is most strongly predictive. I would not want you to leave thinking that there's no point considering intervention in patients who are not likely to be completely cured of hypertension, because the main goal of surgery is to protect the heart. And on this slide, you can see that in patients who go to surgery in blue, there's a large reduction, 80% on average, in aldosterone, and this is paralleled by a mean of 50% reduction in brain natriuretic peptide, reflecting cardiac strain. But in the future, we may think that patients who are not predicted by hybrid steroid measurement, for instance, to have a KCNJ5 mutation, would be better being offered ablation rather than surgery. So let me finish with a word on the gene in which we have recently found mutation, GNAQ and its sister GNA11. Some years ago, we reported women who presented at times of high LH or pregnancy hormone with mutations in a gene beta-catenin or CDNB1, which switched on the level of the pregnancy hormone receptor. But since then, we've realized that these mutations in beta-catenin on the top row here are, in the patients presenting in pregnancy or sometimes puberty, always accompanied by a second mutation in a gene GN11 or GNAQ, which, as the next slide reminds us, is the G protein which mediates the signal from angiotensin to aldosterone in the adrenal. This mutation, in the presence of the beta-catenin mutation, always leads to a very high expression of the receptor for LH or HCG. On the left-hand side, you can see our 10 patients where the LHCG is compared with the adjacent adrenal or a series of other tumours. And on the right-hand slide, this is data from our colleague in Paris, Christina Zanaro, where she additionally has a group of patients where there's a mutation of beta-catenin, but not the second mutation in GN11 or Q. And these patients do not present at times of puberty or pregnancy. So a specific phenotype from a specific genotype, and these patients are always completely cured of their hypertension by adrenalectomy. So in summary, primary aldosteronism causes 5 to 10% of hypertension, but is very rarely diagnosed. Newer techniques based on a molecular understanding of the condition allow us to visualize the tumors non-invasively and to proceed to thinking of radiofrequency ablation rather than surgery. And the ability to genotype the tumor and look for surrogates which predict the genotype in advance will allow us to be more selective and keep surgery for those who will be completely cured of hypertension and protect the heart in other patients by radiofrequency ablation. So I have a large number of people to thank for the work which I've shown you, both in my own group in London, elsewhere in the UK and abroad. Thank you.
Thank you very much, Professor Brown, for your excellent presentation on this very important topic. And there's several questions that come in on the chat now. Is there a role for cortisol secretion in Conn's adenoma?
One subtype of tumor, the one I mentioned with the KCNJ5 genotype, the one which is most likely to lead to complete clinical cure, typically has some co-secretion of cortisol. It's not enough to cause a clinical consequence. The patients aren't clinically Cushingoid, but it's enough to lead to the production of an unusual so-called hybrid steroid, which looks now to be a way of diagnosing these patients in advance and we think recommending surgery as a likelihood of curing their hypertension.
Okay, another question from myself. Are you recommending a renin-aldosterone ratio as the best screening test in all hypertensives now, given 5 to 10% may have a Conn-type syndrome?
Almost. The only thing which is holding me back is we need better advice and evidence as to what we would do with somewhere between 5 and 10% of all hypertensive patients being found to have a diagnosis of primary aldo. So what I would say is the patients who are most worth recognizing are those who are either likely to be clinically cured, which seems to be the younger, particularly the younger women, or those who are likely to get into most trouble from a heart point of view, who are the Black patients who develop the worst cardiac problems, and other patients whose hypertension already looks like going out of control, so the resistant hypertensive. So in summary, I think all resistant hypertensives and all patients under the age of 45 should be screened with renin and aldosterone as early as possible.
Okay. There's a question here, I think perhaps you've answered. In the realm of secondary hypertension, is aldosterone producing adenoma the main culprit or the very rare cause of secondary hypertension?
Primary aldosteronism is the commonest, and certainly the commonest curable cause of resistant hypertension, but it's not the only one. If you measure renin, which, as I've just recommended, should be routine in resistant hypertension, then given that the drugs patients are usually taking a diuretic, calcium blocker, and an ACE inhibitor and ARB, those drugs will all tend to elevate the plasma renin. So the finding of a low plasma renin despite those drugs is highly suggestive of primary aldosteronism. And as our Pathway 2 study showed, these patients will respond very well to spironolactone, and it's a group in whom it may be worth looking for a curable adenoma.
Yeah. And how do you determine the KCNJ5 mutation, somatic mutation? You have to have access to the adenoma, or is there any test you can do peripherally to...
Yeah, so I'd say a very key point. At the moment, the vast amount of diagnosis of genotype is done after we've received the tumour, and obviously that's a bit late to be making a decision whether or not to take the tumour out. However, as I was saying in answer to one of the earlier questions, it looks very likely that the so-called hybrid steroids, so particularly 18-hydroxy or 18-oxocortisol, is a steroid which is only made when the same cell has the enzyme which normally makes aldosterone, which we call CYP11B2, and the enzyme which normally makes cortisol, CYP11B1. And when those two enzymes are in the same cell, which they are in the KCNJ5 mutant genotype, then there's a high level of this hybrid steroid. And this has been suggested by a number of investigators, but we had the opportunity in the MATCH study, which I alluded to in my talk, to measure a steroid profile in every patient. This was done by Professor Wiebe Kowalt in Birmingham. And there's blue water between the level of hybrid steroids in the patients with KCNJ5 mutation and the rest of the patients. So that it needs a bit more dotting I's, crossing T's, but we're pretty excited by that observation.
Okay. And just lastly, is there a role for spironolactone? Is this equally effective to removing the adenoma, or is removing the adenoma the best approach?
In the patients who have lateralized, then there is no alternative to removing the adenoma as a way of achieving the 80% reduction in aldosterone, which I showed you, and which seems to be driving the very large improvement in brain natriuretic peptide and an index on cardiomagnetic resonance. Of course, that was not a randomized study, but the fact that brain natriuretic peptide did not fall on spironolactone is very intriguing and would suggest that the Endocrine Society guidance that if you lateralize, something should be done is true. But again, to repeat a point in my talk, and is concentrated on in more detail in my longer talk, in the future, I think we will hopefully get away from taking out a whole gland for the sake of a 1 centimeter benign tumor. As I sometimes say, not wholly tongue-in-cheek, that's how we used to treat peptic ulcer at the start of probably your and my medical careers, Brian. And we've somewhat advanced, and we need to advance in the field of primary aldosteronism.
I think we have to move on now, Morris. Thank you very much for the question. There are a couple in the chat box that perhaps you can answer, and a hand over to my co-chair, Stephanie Baldwin.
Thank you very much, Morris. That was very interesting, and I would have loved to quiz you a bit more on the cortisol co-secreting stories. So that's for another time. I'm Stephanie Baldwin. I'm a diabetologist at University College London Hospitals. It is my great pleasure to introduce our next speaker, Professor Corinna Brunkhorst, who is a professor of cardiology and co-director of arrhythmias and electrophysiology at the University Heart Center in Zurich, Switzerland. She's very well known. She's widely published. She has a big research experience focusing on the diagnosis and treatment of arrhythmias, especially on atrial fibrillation, ventricular tachycardia, mapping, and ablation. So I would very much like to welcome Professor Brunkhorst for her talk on taking atrial fibrillation to new limits.
Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizers for this very kind invitation. And I also want to congratulate them for their energy and endurance to conduct such an excellent international meeting during these adverse times. My task is to take atrial fibrillation to new limits. These are my disclosures. This is how we diagnose atrial fibrillation on a 12-lead standard ECG or on a 30-second rhythm strip. And this is our patient population, consisting of about 44 million AF patients worldwide. So it's a true pandemic. And in comparison to another pandemic, which keeps our days busy, there are about 22 million active COVID-19 infections. But atrial fibrillation is not infectious, fortunately. The incidence of AF has been increasing worldwide over the past decades, and we know that when the population is aging, that there is also a exponential growth, so that we will expect further increasing numbers in the next decades. The mechanism is well understood for the last 2 decades, at least roughly, that there is the source, the triggers coming from the pulmonary veins, and the substrate are the atria, the structure and the size, and micro-reentry circuits and multiple reentry wavelets are forming. Last year, there was a new edition of the ESC guidelines, which were completely revised since 2016. And the management, which is suggested in these guidelines, ABC of atrial fibrillation, first is focusing on avoiding stroke, which is, of course, of paramount importance, with oral anticoagulation and the NOACs being preferred over the vitamin K antagonists. The second column is focusing on better symptom control. There is rate control and there is rhythm control. Rhythm control, either catheter ablation or antiarrhythmic drugs. There are various drugs which are available for patients without structural heart disease. When there is reduced ejection fraction, there is only amiodarone left. The AFFIRM trial, more than 2 decades ago, tried to answer the question rate control versus rhythm control. And as we all know, it didn't show any statistically significant difference. So the discussion in these last years, the last almost 20 years, was should we really bother of doing rhythm control? We strongly believed in it as electrophysiologists and most cardiologists. But only last year, we really received the evidence from the EAST AF trial being published also in the New England Journal led by Paulus Kirchhoff. There were 2,800 patients randomized to early rhythm control with drugs or ablation to rate control. And here there was a substantial, significant benefit from the early rhythm control, resulting in 28% reduction of cardiovascular mortality, 35% reduction in stroke, which was both significant, and 19% reduction in heart failure hospitalization. So the question is answered between rate control and rhythm control. What about medication and intervention? We know we have to focus with the ablation on the pulmonary veins. The cornerstone of AF ablation is the electrical isolation of pulmonary veins. The standard therapy is radiofrequency ablation with a 3D mapping system. There's also cryoablation. And here we have a pre-recorded CT or MRI image, and we can steer the catheter on this CT map, so to speak, and isolate the veins. This is a recent image of one of our patients. We have the ablation line. We stimulate from inside the vein, and we check for complete isolation, that the stimulus is not reaching the atria. In the first years of catheter ablation for atrial fibrillation, there was a substantial amount of fluoroscopy being needed. Now we can do it purely without fluoroscopy, with an intracardiac echo for the transeptal and the rest with a 3D mapping tool. The Cabana trial has attracted a lot of attention. It was the largest catheter ablation trial ever, being randomized 2,200 subjects to ablation or drug therapy, a substantial amount of crossovers, and the outcome was neutral in the intention to treat analysis, which is the only proper way to interpret a study. But it showed us that AF ablation has a very good safety profile, and it's a very efficient therapy strategy for rhythm control. In the last year, there were 2 ablation trials, the early AF trial and the stop AF trial, both using cryoablation as initial therapy for atrial fibrillation. And these trials showed us that there were significant less AF recurrences in the first year after cryoablation as first-line therapy versus drug therapy, and it was safe. There was also a very low complication risk. This study investigated a heart failure patient, the Castle AF study, and this study was positive, with ablation being clearly superior to conventional treatment in patients with heart failure. In terms of the hardest endpoint in all-cause mortality, and the curves diverging after 3 years. This was implemented in the current guidelines, with catheter ablation being a class 1 indication for patients with heart failure. Catheter ablation also class 1 after failed drug therapy, and it's also a treatment of first choice in the other patient groups with a class B indication. The third column for atrial fibrillation treatment is focusing on comorbidities and cardiovascular risk factors, which has been maybe underestimated in previous years. There's a multitude of risk factors. Some we cannot really influence and correct, and some we can clearly, at least partially, try to influence. We know obesity is a big problem for cardiovascular diseases, also for atrial fibrillation. This Australian study looked at a combination of treatment with catheter ablation and also risk factor management, including weight loss. And the patients with risk factor management had significant better outcome for the AF ablation in terms of AF recurrence. What about the other extreme? What about endurance sports? We know that there's a U-shaped curve with decreasing AF and then rising AF after a intense exercise of about 4,000 lifetime hours. This has been shown for men, like most findings in cardiology. For women, in a few female studies we have didn't show this U-curve relationship. This is also reported in the ERA position paper, which is a pioneering work 3 years ago. That there's the U-shaped curve of AF risk for men, but there is no such thing for female. So exercise reduces AF risk, and women can exercise as long as they have fun and as long as there are not other studies showing us the opposite. The future, there is a multitude of new technologies. I just want to briefly touch upon, there is this artificial intelligence ECG algorithm looking at sinus rhythm ECGs and trying to find the substrate of atrial fibrillation. So trying to diagnose at a sinus rhythm ECG atrial fibrillation. And this study had very good sensitivity and specificity. And there's also emerging technologies for new ablation sources. The electroporation has first been shown at last year's HRS meetings, the first in human trial. This pulse field ablation technology has a few advantages over our conventional treatment, like the radiofrequency and the cryoenergy. It's much faster and it's much more specific. So the adjacent structures like the esophagus and the phrenic nerves are not jeopardized as they can be with radiofrequency energy or with cryoablation. So in our efforts to ameliorate atrial fibrillation, we should have the patient in the center, and we have to collaborate with a lot of different disciplines. Teamwork is key. Thank you very much for your attention.
Thank you very much, Professor Brunkhorst, for that excellent talk on a very, very important topic. I would like to start with a question myself, and that is, many listeners today are not cardiologists, but are nephrologists, diabetologists, general physicians, and we will pick up atrial fibrillation in clinic when we examine the patient. And I wonder whether you would want to give a general pointer of what we should do before we sort of ask our cardiologists to get involved.
Yeah, thank you. Thank you, Stephanie, for this very important question. The most important thing is to pick up atrial fibrillation. I have an echo here. Oh. Okay, can you hear me?
Yes, we can.
Okay, super. Yeah, that's a very important question. Thank you so much. It's very important to pick up atrial fibrillation in the first place. So the guidelines really tell us to have an opportunistic screening from patients above the age of 65 years. So we should take the pulse, or we should write an ECG. So that's the first very important step for people who are not really working in cardiology, to take the pulse and to diagnose, because we really have important implications for stroke preventions and then, of course, for the remodeling aspect. Then when the atrial fibrillation is diagnosed, and this has to be with a 12-lead ECG or with a 30-second rhythm strip, this is the proper diagnosis. Then we should have lab values, including thyroid, including the kidney and the electrolytes. We should then have a one-time, and that then should be the referral to the cardiologist. We should then have a transthoracic echo, and we should look for risk factors. The risk factor management in recent years has become more and more important. So we should look as internists, and also, of course, nephrologists, we should look out for arterial hypertension, which is an important risk factor. And the two pandemics of hypertension and atrial fibrillation are fertile for each other. So these are very important aspects to look out for before the referral to cardiologists.
Thank you, that's very, very useful. We've got a couple of questions on anticoagulation, and I wonder whether, I'm going to put them together. The first one is, who should remain anticoagulated and for how long after successful ablation? And the second question is about, this is a much more specific, actually, again, of who can have an ablation in which situation, due to high bleeding risk. So this is bearing in mind the other risk factors for bleeding.
Okay, so for the first part of the question, after the ablation, we should, that's also what telling us the guidelines. For 2 months, we say 3 months, but at least 2 patients should be anticoagulated after the ablation. This is mandatory. Also for patients who had a CHET score of 0 before, because after the ablation, we put, with the ablations, we put inflammatory reactions in the left atrium. So that's of paramount importance. After the 2 to 3 months period, we should consider the CHET-VEST score and then continue with the anticoagulation thereafter, irrespective of the success of the ablation. So if somebody has a CHET score of 3 or more, 2 or more, one should definitely maintain the anticoagulation. With a CHET score of 1, it's at debate that is considered, but 2 or more, that's mandatory to continue the anticoagulation. And with other words, and I think this implies the next question you were touching upon, when patients come and want to be ablated for the reason of getting rid of the anticoagulation, that is a class 3 indication, so a contraindication. Somebody wants to get rid of anticoagulation, that should not be an indication for catheter ablation.
Thank you, thank you. There's 2 questions coming on wearables. So one is whether when we have an Apple Watch and it says atrial fibrillation, can we trust that? And the second question is whether those wearables have given us an idea of the undiagnosed AF burden in the population.
Yes, there was the Apple Watch study in 2019, which attracted a lot of attention. There was 500,000 of people, not of patients, being involved in that study, and the only 0.5% were then getting an ECG patch for the diagnosis of atrial fibrillation, because these were mainly like young individuals, these were not patients. And so this study was not really helpful, but it attracted a lot of attention. And these wearables, yes, they have a role in patients who are symptomatic. When we have the symptomatic patient who always escapes from the documentation, then it makes sense to have a wearable. But for somebody who has non-clinical atrial fibrillation, meaning who is asymptomatic and who could not be documented, that's not really ready for prime time. That causes a lot of confusion. In any case, with all these gadgets we are having, before really having the diagnosis of atrial fibrillation, we need the 12-lead ECG and we need a 30-second rhythm strip of a proper ECG rhythm strip. The diagnosis cannot be made with atrial high rate episodes, also not from implanted pacemakers or so when we see on the atrial electrode when we see these atrial high rate episodes. So, but these patients have to be followed, and the documentation on a proper ECG has to be emphasized.
Thank you. There's one other question which is about the new ablation techniques, and I'm not sure what it refers to. Is it just saying, are the new ablation techniques quicker to perform?
Yes, of course, there's a lot of studies about that. First of all, our mainstay of ablation is still the radiofrequency energy, because we have the most flexibility in doing also some additional lines which are in debate. When we have a balloon technique, we just focus on the pulmonary veins. For example, the cryoballoon. It's also an established technique, and there has been the fire and ice study from Karl-Heinz Cook comparing the two methods, which were equal. So the cryoballoon is quicker because it's a single shot operation. Now they're also on the horizon, or also implemented now in first studies, single shot radiofrequency technologies. And then there is the high power ablation, where you give a high power for shorter periods of time. And also what I briefly touched upon in my talk, that's the new kid on the block, so to speak, which was presented last year at the HRS meetings, a new technology which is called electroporation, a pulse field ablation therapy, which focuses with very short, in the range of microseconds of ablation, which is just destroying the sacroiliac membrane, and which is very, very specific. And at the end of a procedure, we have an ablation time of only like about 3 minutes. So that definitely would speed up the ablation procedures, and that's also on the horizon.
Thank you. There's another question or two questions on anticoagulation, really asking which anticoagulant would you favor for your patients post-ablation? And the second question is on the role of ablation in patients on dialysis, bearing in mind that warfarin might not be a suitable drug.
Yes, well, which anticoagulation strategy I would prefer. I mean, in the new guidelines, in the guidelines of 2020, it's a clear priority that we should use the NOACs. One of the 4 NOACs should be used over the vitamin K antagonist. That's a class 1 indication, unless, of course, there's a mechanical valve. Which one of the 4, that is really an individual decision. That is precision medicine. There's a lot of pros and cons for each one or the other. When there's, for example, the cutoff in the filtration rate, in the kidney filtration rate, about 50 for the Xarelto. There I would favor another of the NOACs, because when you're just around this cutoff value, you should really have another one where you are not around these cutoff values. But in general, there is not one which is better than the other. They all have shown an amazing safety profile and also efficiency profile, and they have been proven to be better than the vitamin K antagonists. So that is clear. All the rest is precision medicine. And then having an ablation for kind of sparing the anticoagulation, that's a very difficult question to answer. That should not be the only indication, and often patients on dialysis, sometimes they are very frail and they carry also an additional risk for the ablation. So this is not something which one can answer in general. Of course, the dialysis is not a contraindication for the ablation, so that should still be considered. But there's a lot of factors playing a role to come to the conclusion which is the best rhythm control strategy for such a patient.
Lovely, thank you. And I think we've got time for one final question. You may have sort of answered at the beginning. The question is saying if there are short bursts of AF in a high-risk patient, so multiple very short bursts, which are less than the 30-second which you would need for a diagnosis, what would you do really?
Well, if we have atrial fibrillation on a 12-lead ECG, that basically fulfills already the diagnosis for the guidelines that we have, a diagnosis of atrial fibrillation. And the 30 seconds just refers to the rhythm strip. Okay. But in general, it's much more important really to look at the Jets-West score. It's important to look at the general situation if the patient is at risk for stroke. Because if we have bursts of atrial fibrillation, which we just pick up in a short ECG, we can be almost sure that this patient also has atrial fibrillation on a larger scale. And we should definitely anticoagulate, not on the basis of the burden. We know this, if it's paroxysmal, persistent, or permanent, we should definitely anticoagulate this patient. So also what's important sometimes to look beyond the Jets-West score to make this decision. I'm really interested also in the atrial size. If the atrial size is enlarged, so there's a bigger risk of atrial fibrillation and also a bigger risk of clotting. Also, if there's mitral regurg and things like that. So there are a lot of factors. But if we diagnose atrial fibrillation on an ECG, we make the diagnosis, and then we should have all the different examinations, what you ask in the very first question, and then we should have a strategy looking at the Jets-West score, anticoagulate the patient, and we should look for a rhythm control strategy, and the rhythm control should be superior to a rate control strategy.
Lovely. Thank you very much, Professor Corinna Brunkhorst, for sharing your great expertise with us. That has been a very, very useful, interesting talk. Thank you very much, and greetings to Zurich.
Thank you so much, Stephanie. Thank you, and thanks to everyone.
But I'm passing on to my co-chair, Professor Brian Rayner now, who will introduce the next speaker.
Thank you very much. It gives me great pleasure now to introduce Professor Christopher Wilcox from the Georgetown University, Washington, D.C. He was Chief of Nephrology at that university for 24 years until 2019, and is now currently Professor of Nephrology and Director of the Hypertension Center. Professor Wilcox has extensive recognition as a researcher and an outstanding research record with over 350 publications and 2 books which were widely read. And with great interest, we will hear his topic, Diuretic Resistant, New Tricks for an Old Problem. Professor Wilcox.
When Professor Yellen sent me his kind invitation to speak at this outstanding meeting, you can see that his title gave me the challenge of talking about the novel aspects of this subject. And after a single introductory slide, that will be the focus of my talk. So here we see the normal response to a loop diuretic given during a high salt intake in the top or a low salt intake in the bottom. And it shows sodium excretion in millimoles per 6 hours. And the first intravenous dose of furosemide increases the salt excretion remarkably, as you'll see in gold. But the interesting finding is that afterwards there is a period of 18 hours of renal salt retention, such that over the 3 days of diuretic administration on the high salt diet, the salt lost with the diuretic was matched quantitatively by salt retention after the diuretic and no negative salt balance. On the low salt diet below, although there was salt loss with the diuretic, there was no way the kidney could restore salt balance because no salt was present in the diet. It reminds us of the importance of post-diuretic salt retention and also the need to consider and restrict dietary salt intake. In a study by Jeffrey Testani, he assessed proximal and distal reabsorption by lithium clearance in a group of patients with diuretic-resistant heart failure and concluded that about 3/4 of the resistance was due to enhanced reabsorption downstream from the site of the loop diuretic. In this talk, I'm going to discuss with you strategies to enhance delivery of salt to the diuretic-sensitive segment by blocking proximal reabsorption with hydralazine or SGLT2 inhibitors. The use of improved loop diuretics, notably extended-release torsemide, and the concept of a sequential nephron blockade when multiple nephron segments are blocked simultaneously. In this study here, as a patient with severe diuretic-resistant heart failure was given escalating diuretics up to 220 milligrams per hour of intravenous furosemide and 500 milligrams twice a day of chlorothiazide. But still her fractional excretion of sodium was less than 2. The addition of 10 milligrams 3 times daily of hydralazine doubled the FeNA and the daily urine output to 3.5 liters and allowed her discharge from the intensive care unit. Hydralazine certainly increases blood flow to the kidney and therefore delivery of diuretics to their site of action, but we thought that was unlikely the major cause of the natriuresis here because she was getting the drugs at supramaximal doses round the clock. It also reduces the filtration fraction by a hemodynamic effect and thereby reduces proximal sodium uptake and therefore acts as a proximal diuretic. And we thought that was the more likely site of action in this case. This shows the response of normal subjects to the traditional dose of a traditional form of torsemide in red, or a novel formulation that releases torsemide slowly into the blood and the urine in green. And you'll see in the first panel that the time to maximal effect was increased 3.5-fold, with a corresponding change in the middle panel in sodium excretion, which was both more prolonged and extended over the period of what would normally be post-diuretic salt retention with a traditional immediate-acting diuretic. The net effect, as shown in the middle panel, was to double the sodium output in 24 hours, and in the last panel to increase the amount of salt excreted per unit of diuretic reaching the urine, again by about twice. SGLT2 inhibitors are drugs of great interest and block proximal sodium reabsorption linked to glucose, but in normal kidneys this is fairly trivial and amounts to about 5%. However, it's apparent that SGLT2 is structurally and functionally linked to other transporters, notably sodium hydrogen exchanger 3, which reabsorbs the bulk of proximal sodium reabsorption. Therefore, blocking SGLT2, as shown in the bottom panel, simultaneously blocks NHE3 and other proximal reabsorptive pathways, and leads to a large increase in the delivery of sodium and chloride from the proximal tubule into the loop of Henle. And we hypothesized then that this would lead to synergy with loop diuretics. And this is shown here, that in the first panel, the SGLT2 inhibitors increase the amount of salt delivered to the target for loop diuretics and should therefore increase their responsiveness. Whereas on the right, we show that loop diuretics, by increasing renin and angiotensin, enhance the expression of SGLT2 and NHE3 in the proximal tubule, and therefore the target for SGLT2 inhibitors. And when we tested this in normal subjects, you'll see that bumetanide alone in the green increased sodium excretion by about 115 millimoles in 6 hours. But when given after a week of dapagliflozin, the natriuresis was increased by about 1/3. In the right panel in blue, dapagliflozin alone is a relatively feeble natriuretic agent, increasing sodium excretion less than 40 millimoles. But when given after a week of bumetanide, remarkably, the dapagliflozin now increases sodium excretion by an amount equivalent in green to a normal loop diuretic, about a 3-fold increase, showing mutual two-way synergy between these two groups of drugs. Lastly, it shows the concept of sequential nephron blockade. If loop diuretic resistance is due to enhanced reabsorption at other sites, and if this also sets up the electrochemical environment for more potassium secretion and hypokalemia, then it may be logical to consider the use of multiple diuretic agents together to block not only compensatory sodium reabsorption, but also potassium secretion. Indeed, as you see here in this study of 17 patients with acute diuretic-resistant heart failure, the infusion of furosemide, spironolactone, metolazone, a thiazide, acetazolamide, a proximal diuretic, and tolvaptan, an acquaretic, together led to the loss of 7 kilograms over 4 days without any measurable change in electrolytes, blood pressure, or GFR, likely because these subjects were being forced to excrete what is really a hardly modified glomerular filtrate. Further studies will be necessary, and I know are underway, to see if this can be shown to be a reproducible and clinically useful strategy. Lastly, putting this together then, in heart failure we need to consider neurohumeral blockade with ACEs and ARBs, for example. Hydralazine may add to this by reducing proximal reabsorption. And in addition to a loop diuretic, we can consider an SGLT2 inhibitor blocking proximal reabsorption, a thiazide, a miloride, or a mineralocorticosteroid receptor blocker such as spironolactone blocking downstream, and should always remember to consider reducing dietary salt intake. Thank you very much.
Thank you, Professor Wilcox, for that excellent talk on new tricks in treating diuretic resistance. And we have a question already. Should diuretic dose routinely be decreased when initiating a sodium glucose transport inhibitor in patients with well-controlled volume status?
Well, it's a good question because our study did indicate a synergistic natriuretic effect between the two. But frankly, that's usually a beneficial interaction when the drugs are used in a patient with heart failure, let us say. Generally, SGLT2 inhibitors are relatively free from adverse renal effects, although they do cause, as is well known, an early fall in GFR or rise in creatinine that is part of the beneficial response, in fact, in reducing hyperfiltration in patients with CKD. This is a hemodynamic response and should not initiate any dose reduction or change in strategy. So although theoretically there may be a significant enhancement of volume loss that may not be required, in general, it's a useful additional effect of SGLT2s when added to diuretics, and it doesn't usually need to reduce the dose of the diuretic.
Okay, thank you very much. A question from myself. In some of the heart failure studies suggested sodium glucose 2 inhibitors prevent progression of kidney disease or prevent acute kidney injury. What is the possible mechanism of this?
Thank you. So it's still not fully established in clinical studies, but there are very good experimental studies in rat and mouse models of diabetic nephropathy. And the study by Scott Thompson and colleagues in such a model showed quite convincingly, I think, that SGLT2 inhibitors, by reducing the reabsorption of salt and water in the proximal tubule, increase the delivery to the macular denser segment in the loop of Henle that activates the tubuloglomerular feedback response. Now, if you think back to medical school days, you may remember that tubuloglomerular feedback is a response of the tubules that leads to vasoconstriction of the afferent arteriole and thereby reduction in the glomerular capillary pressure. And that is probably a key but not unique component of the beneficial response. The off side of it is that one must anticipate then, if hyperfiltration is being combated in such a situation by SGLT2 inhibitors, the creatinine will rise by approximately 10% during the early phase of treatment. There are certainly many other beneficial effects that have been reviewed, but that is, I think, a prominent mechanism, at least in animals.
Okay, another question. Sacubitril, is this an adjuvant to diuretics and has a similar mechanism of action to sodium glucose transport inhibitors?
It's a good question. It likely reduces proximal reabsorption and so may indeed have a similar mechanism. Where it would be additive or not has yet to be seen. The drug hasn't been very fully established as a means of treating diuretic resistance. Little study on that. The focus has been mainly, as you know, on heart failure, but I think it would be time to consider such an additional action. That's a nice question. Thank you.
Why is furosemide always our go-to diuretic? Are there better options, or is this just old habits?
Well, I think you said it yourself. It is indeed a reflex response to write furosemide or Lasix when we think about we need a diuretic. And indeed, in pharmacological studies in normal subjects, it's very predictable and causes a very large increase in salt and water excretion. But we're all too well aware that as a therapeutic option in patients with heart failure, although they may be so-called dried out and released from the intensive care unit and discharged home, they frequently return with a repeated congestion. And some of this may relate to the poor pharmacokinetics of furosemide, because it has a very variable bioavailability, anywhere between 10 and 80%, which is greater than, I think, any other marketed drug, frankly. And that means that its effects are very unpredictable patient to patient. Torsemide is eliminated by metabolism, whereas furosemide by glycosylation. Metabolism much more predictable, giving it a predictable and high bioavailability of greater than 80%, and less potassium, less hypokalemia, interestingly. So most people who have reviewed the subject have come to the conclusion that torsemide would be a better choice than furosemide for routine use in heart failure.
Okay, thank you. Now, sodium glucose transport inhibitors appear to reduce heart failure and can work in heart failure. Is this due to their primary mechanism of action, or are there other aspects to the prevention of heart failure? What is your viewpoint on this?
Well, it's a terrific question and one that stimulates a lot of interest. When Ernie Wright described SGLT2 expression, he showed it was confined to the early part of the proximal tubule. Many studies since have shown that at the RNA level, the expression at that site is 100 or more fold greater than any other site. In other words, it's almost uniquely expressed at that site. If that is the case, then presumably the mechanism of action is primarily related to its effect in the early proximal tubule. And then we have to explain how it has such beneficial effects on the heart. And there are a lot of interesting ideas for that, but I'd say it's a question that I could go on talking about for a while, but it remains unresolved. And I think experimentally we should search as much as we can to explain the effects of SGLT2s by their known effects to inhibit SGLT2 in the early proximal tubule. As I mentioned, linked to NHE3 and other proximal transporters, which gives it a an augmented proximal action.
Are there any outcome studies with diuretics that shown that they are definitely reduce morbidity and mortality in heart failure studies, other than the SGLT2 inhibitors?
Well, there are some but it's really considered unethical not to prescribe diuretics in patients with congestion. So it's not been possible to do the classic studies that would establish them and quantitate their importance. So I think we have to say that the evidence is pretty weak in that regard, but nevertheless, they remain, as we all know, an essential part of the treatment of patients with congestion.
Okay, one final question quickly. Torozumab versus bumetanide, is there any difference? Would you still prefer torozumab?
Bumetanide is like torsemide, eliminated by metabolism, and therefore it has a more predictable PK or bioavailability than furosemide, which may be an advantage. However, it's even more short-acting, as you know. So that is why we have pursued the strategy of a novel formulation of torsemide with an extended duration to try to combat the problems of loop diuretics due to their very short action on the tubules.
Okay, thank you very much, Professor Wilcox, for your outstanding presentation. I now must hand back to Professor Derek Yellen to close the meeting. And I see Peter Libby is back on screen, I hope. Thank you.
Thank you very much, Brian and Stephanie. That's the end of day one, and we hope you'll agree that our colleagues from across the globe have certainly brought us some thought-provoking and very interesting presentations. It has also been a pleasure to have your input throughout the evening via the chat function. This is truly very much appreciated. We would ask you to keep watching for another 60 seconds or so as a reminder of how to obtain CME accreditation. And we'll be back tomorrow at the same time, that is 1 o'clock UK time, for our second day of cardiology, diabetes, and nephrology at the limits. Many thanks for joining us, and we look forward to your company tomorrow.